Thanks, Ramika, for those questions. And I feel of all the debates today, this is a greatly skewed one because I found nothing wrong with your presentation per se. And I hope that's the case here also. This FFA versus ICG is so skewed a debate and so skewed a thing in uveitis, especially like it's combining both empire and the first order against a little baby Yoda, just to say. Uh, it's a younger sibling of FFA. I give you that. It was introduced later than FFA, and if you just Google FFA versus ICG, this was ICG comes up only 447,000 times, while FFA is has 2 million hits on Google. Similarly, we have lot less number of publications on PubMed, both in uveitis and non-uveitis thing. Uh, on published literature. So do we have enough data to say ICG is poor or better? I doubt. So it's a younger sibling, and whenever use the word sibling, it's I guess ICG is not separable from FFA. I give you that. Second thing, when you want to image choroid, what do you do? If I want to see wild animals, I would like to go to the jungle than see it in a zoo. And ICG has a better penetration. So if you see this was a case of VKH, and I give it to FFA that disc, retina, outer retina, and RP is definitely imaged a lot better on angiography, and it takes up very nicely the retinitis lesion identification, pinpoint leakages, vasculitis, everything is there. What it cannot see is the jungle behind. It cannot see these smaller granulomas. It cannot see that there is a choroidal vessel inflammation, and that's a very important thing that it brings to our minds. It might not give every patient a clinical advantage, but it definitely adds to the scientific knowledge that there is choroidal inflammation. These vessels are in fact hyper, and both the excitation and emission spectrums of this is in the infrared spectrum, unlike the angiography, which helps it penetrate the RP till some extent. Heme, exudates, and even melanin can be penetrated by these waves of ICG. And again, I was saying you, when imaging choroid on angiography, the big problem is retinal pigment epithelium. We have window defects through which we can see sometimes staining of the scars, or RP in the mid or late phases has problems. Pinpoint leakages at the level of RP has problems of imaging. It's like this picture again, where you see some kind of hypo are seen on angiography, but it's like looking from the ground through a telescope through all of the atmosphere, and its problems hidden therein. And how do we get a better look at choroid? Like they found out just the Hubble telescope, put it out of the atmosphere, uh, bypass the RP, and get the image that you have a choroidal inflammation. And still better, like the recently launched James Webb telescope, we have an Optos or any wide field imaging where you can have a much wider view nowadays, where in this case of toxoplasma, where you could see a more than involvement of choroid than you could see on either angiography or clinical photograph. So it nowadays gives a wider extent as well. And this was also a point that you mentioned, that it's the truest extent of the disease, especially the choroid, is given by none other than ICG. Yes, it could be few spots here and there, but details matter. And coming to the next thing, it really scores if it's any one disease. I would pick leakage for that, and I guess this would be applicable for cases of sympathetic ophthalmia as well, given the clarity. And these are the 4 points that are seen other than the diffuse delayed choroidal perfusion. I'll cover this in more details next 2 slides. The first is ICG use a marker of acute disease, disc hyper and disc. These are the choroidal vessel hyperfluorescence that we get to see in an acute disease. However, these are not seen in chronic uh, diseases. also, we have two clues for an underlying inflammation. One is these hypofluorescent dark dots, and other it lays late fuzziness of choroidal stromal vessels. Now, Anamika questioned me that what are the cases in which I would really like to go for an ICG, and over the past couple of years, I've developed this particular algorithm for myself, and to the residents listening today, this would be the slide I will carry home. So I do it especially in the cases with atypical cases where either I clinically see it to be asymmetrical or clinically unilateral disease to look for the choroidal involvement, or if in very rare cases there are disc edema and hyperemia only as a presentation, which is quite rare. Subclinical activities, again, a very big point where I do ICG, where we see continued depigmentation or sunset glow despite you having been on treatment. And the second point in the subclinical is helping nowadays a lot. That is when tapering the systemic immunosuppression when the patient has been on to say 2 years, 3 years plus, and I want to taper the dose of the immunosuppression. Nowadays I've started doing an ICG, of course, with an FFA to see that there is really no subclinical activity. And also cases of recurrence of leakage at most of the times are anterior, and ICG is helping me to see that on the posterior there is any involvement as well. The fifth point I want to stress is this is one area, the tuberculoma, though clinically there are vitritis, other signs of inflammation, very rarely it could be differentiation from amelanotic melanoma might be a necessity. The difference is tuberculoma stays hypo throughout, early and late on ICG, while amelanotic melanoma will be otherwise, it would have vasculature inside on ICG and other things. So this is one more area where if a silent sitting tuberculoma is there and the diagnosis is a query, this would help. The sixth point is this dye. There is very less extravasation of the dye from the vasculature, and like we have all of this leakages on FFA, we get minimal extravasation of the dye, and we can see the choroidal vessels quite clearly as opposed to the FFA. So in summary, ICG depicts the extent of choroidal involvement better than FFA. Especially two things that stand out on ICG are granulomas and choroidal vascular inflammation. So really the idea of vascular inflammation might not be given exactly by the FFA. And the last point is the ICG is nowadays helping me, and recently I've published articles as well, the subclinical choroidal involvement, which is better than FFA. Yeah, thanks everyone. I would like especially to thank Dr. Chitra and the team for giving me the opportunity to present this, especially before this August panel.
Thank you very much, Anup. Both you and Anamika were absolutely strong and clear about the message you wanted across. So I'm now going to bring that discussion on. I'm going to ask Ratnam one very simple question. Would OCT angiography replace FFA and ICG? And your thoughts on that?
No. FFA is most important.
Srinivas, you have any questions?
Sir, Avinash sir, I just want to ask about these two things. Say, when you know that in case of choroidal, they consider the mutes or the APMPP. In those cases, I agree with Anup that they have a very clear distinction of the lesions, especially when you are treating these diseases. Because sometimes the FFA gives a very fuzzy this thing, and reactionary leakage happens, pooling happens. So how will you monitor the treatment aspect of the, especially in case of choroidal? I think ICG still holds a hand better as compared to the FFA. Although FAF is the game changer, but when the debate comes only between the FFA and the ICG, what would you really like to prefer, sir?
So my one answer, FFA. That's it.
My answer is FFA, ICG both.
Ratina, madam?
FFA.
I think it would depend on what is the disease we are dealing with. If it is primarily a retinal disease, we would prefer FFA. And when we are looking at choroidal granulomas or a suspicion of choroidal, it is ICG. So it cannot be one for all.
For vasculitis, I don't need FFA, ICG, but other conditions I need FFA and ICG both.
choroidal infiltration because of masquerade syndrome, ICG is very important.
Thank you. A lot of information came through this